Hi guys, welcome to another lecture, and today we'll be discussing something about neonatal thrombocytopenia. So neonatal thrombocytopenia is a very important topic, and it is one of the most common encounter hematological clinical feature that sometimes you might have seen, and it is technically labeled when the platelet count is less than 1,50,000. Okay, 1,50,000, and it occurs in around less than 1% of newborns. Okay, though it is very common in India because of the high prevalence of sepsis. In developed countries, the prevalence is lower, and the differential diagnosis of thrombocytopenia and the cause of thrombocytopenia sepsis is very below in the list of line or the etiological diagnosis in those patients. So that is very, very important. This is the basic, and I hope you have understood about it. Now, why this? See, firstly, you have to understand the normal physiological process of platelet growth. So first, you have to understand that there is something known as thrombopoietin. And this thrombopoietin is actually the stimulus of the production of megakaryocytes, and then this thrombopoietin will lead to presence, generation and proliferation of megakaryocytes. Okay, then after this there is maturation. There is maturation of megakaryocytes. Maturation of megakaryocytes into the platelets that we know. So this is how it occurs. Now there are some salient features. There are some features in newborn compared to adults. So the levels of thrombopoietin in neonates are low compared to adults. So, whenever the adults face thrombocytopenia or even in physiological condition, the levels of thrombopoietin are less compared to adults. And due to this, the stimulation is not adequate whenever there is very high amount of destruction. Along with this, the megakaryocytes are smaller in newborn. Megakaryocytes are smaller in newborn. Okay, so this is a salient fact of the newborn. And once there are increased destruction, like there is necrotizing enterocolitis, there is sepsis, then the stimulus is not adequate to cover up the increased destruction. Now, what is the normal physiology of platelets? So platelets are 1/5 of RBC. The size of platelet is 1/5 of the RBC size. Along with this, the mean volume or the mean volume is 7 to 9 femtoliter. The mean volume of RBC is 7 to 9 femtoliter, and the T half or the half-life of the platelet is very short, 7 to 10 days. Okay, so this is the basic about a normal platelet in a newborn, and this is the normal levels are 1,50,000 to 4,50,000. Okay, now along with this next will be the pathological things and the clinical features. So firstly, you have to understand that if the levels are more than or equal to 1 lakh of platelet, there is no increased risk of bleeding. See, there is zero increased risk of bleeding in the patients whenever the levels of platelets are more than or equal to 1 lakh. Okay, so after this level, there is no increased risk of bleeding. Now, after below this levels, like between the values of 20K to 1 lakh, there is mild increase. There is mild increase. Less than 20, like between 5K and 20K. 5K and 20K, there is a moderate risk, and below 5K, below 5,000, there is very severe risk. Okay, and usually many centers, they actually have different guidelines. That some centers say that below the levels of 20,000 we will transfuse platelets, the others say that less than 50,000 we will transfuse the platelets. So this was basic about thrombocytopenia. Now, how to approach a patient with thrombocytopenia? A newborn with thrombocytopenia will be diagnosed as the following algorithm. So first is that if the child is a term infant, if the child is term infant and the platelet are less than 1 lakh, okay, or it is more than 1 lakh. So depending if the child is term or if the child is preterm, okay. So if the child is term or if the child is preterm, depending upon what the child's gestational age is, the diagnostic algorithm changes. Okay. Okay. So in less than 1 lakh, we will differentiate in term as if the child is sick looking or if the child is healthy looking. Okay. And if it is more than 1 lakh, then the only thing that we do is observe. And also in preterm, we observe. And we follow up after some time. If it is persistent, then we investigate. If it is temporary or if it is for a short duration, then we do not do anything. So this is the following algorithm, that if the child is sick, then there is a list of etiology. There is a huge list of etiologies, and we will see those etiologies. But if the child is healthy and the platelet are less than 1 lakh, you observe. If persistent, then treat. Okay. So this is the important algorithm that you need to understand. Fine. Now, along with this, there are multiple syndromes that you need to make sure that you are discussing, you are actually ruling it out, and you are keeping it at the back of your mind. Because if you do not remember this, you will not be able to see this. So first, the etiology. Okay. So first is immune. And in immune, we will be discussing there are two types of immune. One is alloimmune and second is autoimmune. Now, what is alloimmune and what is autoimmune? We will be seeing them separately, but basics. Alloimmune is that, see, there is a parent, there is a paternal antigen that has been inherited, and that antigen is, the one that is being attacked. Okay, so that is alloimmune. Autoimmune is that the mother is suffering from any XYZ autoimmune disease. So due to that, those antibodies cross react. Okay. So alloimmune, neonatal alloimmune thrombocytopenia. Okay. While in autoimmune, there might be diseases like maternal ITP, systemic lupus erythematosus. Okay. So all these diseases are there. Next is the infectious disease. Very important infectious disease. India, very, very, very important. Bacteria, most important, most common cause of death. Might be viral, might be fungal. Then next are placental insufficiency. IUGR, placental insufficiency. Okay. Then diffuse intravascular coagulation. Then genetic diseases. Genetic diseases are very important, like trisomy 13, trisomy 18, trisomy 21, like Turner syndrome, Jacobson syndrome, Prescott-Aldrich syndrome. Okay. Then X-linked thrombocytopenia, TAR syndrome. Okay. Then Fanconi's anemia. All these genetic disorders are there which cause thrombocytopenia. Drug induced. So heparin induced thrombocytopenia, also known as HIT. Okay, then vancomycin, phenytoin, and then there are miscellaneous causes like hemangiomas hemangiomas which cause the usage of the platelets, which is also known as Kasabach-Merritt phenomenon. Kasabach consumptive coagulopathy. Okay, consumptive coagulopathy is there. So Kasabach-Merritt syndrome. So this is the basic etiologies. Now we will be understanding them in depth. So first condition is neonatal alloimmune thrombocytopenia. So alloimmune thrombocytopenia is caused by presence of a paternal antigen which is denoted as human platelet antigen, okay, HPA, and this HPA are usually of 16 types, and among them they are majority cause of this autoimmunity. This paternal antigen will cause newborn platelet to have an antigen which, when crosses to the maternal side, leads to maternal antiplatelet antibody. Maternal antiplatelet antibody, and which causes the havoc in the patient. Now, along with this, usually the most common cause is HPA, human platelet antigen 1A, and this is responsible for around 75% of the all cases. Usually, these patients have mucocutaneous bleeds. Mucocutaneous bleeds because platelet type bleeding is mucocutaneous bleed, and it can also occur in first pregnancy. Okay, without any previous sensitization. Okay, the most serious complication is intracranial hemorrhage, and the treatment of this condition is either washed maternal platelets, mother washed maternal platelets to remove the antibody, or you can use HPA1 negative platelet concentrate. So either of them can be used, and once this has been diagnosed, there are very high chances of recurrence. So if the patient if the mother has a diagnosed, like if the pregnancy is diagnosed as having this, the next pregnancy, whenever it occurs, it should be tested early, and IVIG and steroids should be given as early as 13 weeks of gestation. As early as 13 weeks of gestation in the next pregnancy. So this is about the neonatal alloimmune thrombocytopenia. Now next is neonatal autoimmune thrombocytopenia. So neonatal autoimmune thrombocytopenia is that, the mother is having an autoimmune disease. So mother plus child will have clinical features, and this may be asymptomatic before pregnancy, and directly the autoimmune disease may manifest in the pregnancy. Okay, the history might be negative, and the patients might be unaware of the autoimmune condition before the diagnosis of pregnancy. Okay, so this is the important part. Then the next are syndromes like Bernard-Soulier syndrome. Now, this Bernard-Soulier syndrome, this is a platelet function defect. Where you have thrombocytopenia, giant platelets, and mucosal bleeding. The dysfunctional platelets are there, so mucosal bleeds are there. Okay, the defect is GP The defect is in GP1B9. The GP1B9 defect is there, and see, it is also, there is also associated absence of CD41A. So this is the defect that is seen in Bernard-Solian and Glanzmann. You might know that there is 2A. Okay, so this is very, very important. And along with this Bernard-Solian, the patient might present with neonatal thrombocytopenia. Next is Wiskott-Aldrich or WASP. Now, this Wiskott-Aldrich has, the Wiskott-Aldrich patients have dermatitis, small platelets, and immunodeficiency, and this is a X-linked recessive condition. Microthrombocytopenia is there, and this is Wiskott-Aldrich. So this might also present as neonatal thrombocytopenia. Next is Fanconi's anemia. Fanconi's anemia is very, very important. We have discussed it. It might have aplastic anemia. Aplastic anemia with morphological features, absent thumbs. Okay, there might be skin lesions, urinary tract abnormalities, okay, microcephaly, and we will go for the testing where we used the deoxybutane, the sensitivity of deoxybutane, where the DNA breakage is very easy. So that is usually the diagnosis. Next is the TAR syndrome, thrombocytopenia with absent radius. Now, this condition has transient thrombocytopenia, which usually resolves by the age of 1 year. And usually these patients have absent radius, but they usually have presence of thumbs. Okay, so this is the difference between both of them. Females are more affected than males, and the patient might require a symptomatic treatment, or the patient might get well on their own. So this is about give me a minute. Yeah, then the next disease that we go for is the giant platelet syndromes. Okay, so these are the important syndromes, and it is a list of 3 primary we will be discussing. Giant platelet syndromes, where you have large platelets, but there will be thrombocytopenia. So there are 3 diseases that you need to know about. One is May-Heglin anomaly. Now, this May-Heglin anomaly has giant platelets with dual bodies in leukocytes. Okay, so May-Heglin anomaly. Then the second is known as the Fletcher syndrome. And Fletcher syndrome has no leukocyte inclusions like dual body, but they might have presence of sensory neural hearing loss, nephritis and cataract. While the third syndrome, which is associated with the giant platelet and thrombocytopenia, is known as Epstein syndrome. And this Epstein syndrome also has some degree of SNHL and nephritis, but again, they do not have presence of leukocyte inclusion bodies. So that is about the giant platelet syndrome. There are also other syndromes like Jacobson-Paris syndrome, but those are not very, very important to remember. Now, next is Kasabach-Merritt phenomenon. This is consumptive coagulopathy, where there is microangiopathy, hemolytic anemia with decreased platelets, and there are hemangiomas. These hemangiomas cause the consumption of platelets. The endothelium cause consumption of platelets, which cause the entire usage of platelets, which lead to thrombocytopenia. This is treated by angiogenesis inhibitor bevacizumab. the same one that is used in retinopathy of prematurity, bevacizumab, and it is a it is mTOR, it is a VEGF inhibitor, VEGF inhibitor, and even mTOR inhibitors like rapamycin can be used in these conditions. So this is about the thrombocytopenic disorders in newborn. I hope you like this video, and I will see you in the next one.